All right, let's talk about something that is a must-know for your anesthesia finals, the west zones of the lung. I promise, in the next few minutes, we're going to break this down so it's super clear, makes perfect sense, and actually sticks in your brain when you're sitting that exam.
So the entire concept, the whole reason we're even talking about this, boils down to one simple question. If you're standing upright, why isn't your lung working the same way at the very top as it is at the very bottom? The answer, you guessed it, is gravity. And once you understand how gravity pushes and pulls on everything in the chest, the west zones just click.
So here's how we're going to tackle this. First, we'll look at the two big things gravity does. Then we'll see how that leads to this thing called a VQ mismatch. After that, we'll actually decode the three west zones, figure out where the infamous zone 1 shows up, and wrap it all up with the clinical takeaways that you really need to know.
Okay, let's get back to basics. To really get the west zones, you have to realize gravity is playing a double agent. It's pulling down on the blood flowing through your lungs, that's perfusion, and it's also pulling down on the lung tissue itself, which affects your breathing or ventilation. Let's start with the blood.
Now this is where the numbers get really interesting. Your lung is about 30 centimeters tall. That column of blood creates a pressure difference of about 22 millimeters of mercury from top to bottom. Now, in your systemic circulation, with its high pressure, who cares, right? But in the pulmonary circuit, which is a super low pressure system, the mean arterial pressure is only about 15, 22 is a huge deal. It means blood flow is just pouring into the base of your lungs compared to the trickle it gets at the top. So that's blood flow. But remember, gravity is also pulling the lung itself downwards. This stretches the top of the lung, making the intrapleural pressure up there more negative. Think of the alveoli at the apex like tiny balloons that are already partially inflated. They're tight, they're not very compliant. But the alveoli at the base, they're kind of squashed and floppy. They have way more room to expand when you take a breath. And because of that, more air naturally flows to the base. So ventilation is also greater at the base. Okay, so let's put it all together. We've just said that both ventilation, V dot, and perfusion, Q dot, are higher at the base of the lung. But, and this is the absolute key to the whole thing, they don't increase by the same amount. This little table tells the whole story. Look at the apex. Yeah, ventilation is low, but look what happens to perfusion. It absolutely plummets. So you end up with way more air than blood, giving you a high VQ ratio. Now look at the base. Both are high, but perfusion goes through the roof. You've got tons of blood, maybe even more than the air can handle, which gives you a low VQ ratio.
So here's a really important distinction for your exams. When you hear VQ mismatch, your brain might jump to pathology. But in this context, it's completely normal. It's the expected, healthy, gravity-driven state of the lung. This is physiology, not a problem.
And this is where the genius of Dr. J.B. West comes in. He took these effects of gravity on blood and air, and he added one more crucial piece to the puzzle, the pressure of the gas inside the alveoli themselves. And for us in anesthesia, that is a game changer.
And here it is, the whole model. Everything we're about to talk about comes down to the constant battle between these three pressures. Alveolar pressure, which we'll call PA, arterial pressure, PA, and venous pressure, PV. The pecking order between these three pressures is what defines each zone. Let's start with the easy one, zone 3, down at the base of the lung. Down here, gravity has made both the arterial and venous blood pressures so high that they easily beat the alveolar air pressure. This means the blood vessel is held wide open 24/7. Blood flows through continuously, no problem. This is our high perfusion zone.
Now things get a little more interesting as we move up to the middle, to zone 2. Here, the arterial pressure is still strong enough to push blood in, but the venous pressure has dropped off so much that it's now lower than the alveolar air pressure. So the alveoli can actually squeeze the end of the capillary. It's like someone is gently stepping on the end of a hose. The only time blood can get through is during systole, when the pulse of arterial pressure is strong enough to force the vessel open. It's not continuous, it's like a waterfall. And finally, we get to zone 1, at the very top. Now I want you to burn this next sentence into your brain for the exam. In a normal, healthy person who's breathing on their own, zone 1 times does not exist. It's a theoretical space where alveolar pressure would be so high, it would crush the capillary completely flat, stopping all blood flow. You'd have air, but no blood, pure dead space. So if zone 1 isn't supposed to be there, the big clinical question for us is, well, when does it show up? Because when you see it, it's a huge red flag. It tells you something is very wrong or that something we've done has drastically changed the patient's physiology.
And it really boils down to two main scenarios you need to have on your radar. Either your patient's pulmonary arterial pressure tanks, think massive blood loss, hemorrhagic shock, or, and this is the one we control, we artificially crank up the alveolar pressure. We do this every time we use positive pressure ventilation, especially with high PEEP. Both roads lead to the creation of that wasteful, inefficient Zone 1.
All right, let's bring this all home. This is the so what section. How does all this theory actually impact what we do in the operating room every day?
This is probably the single biggest takeaway for us. The second we start positive pressure ventilation, we are actively messing with this whole delicate pressure balance. We are jacking up the alveolar pressure, PA, everywhere. And by doing that, we are inherently pushing the lungs towards creating more Zone 1 and Zone 2 conditions, which means more dead space and more wasted ventilation.
I can almost guarantee you'll see an exam question about this. Why does your pulmonary artery catheter have to be in Zone 3 to get a good wedge pressure? Well, think about it. It's only in Zone 3 that you have that uninterrupted column of blood from your catheter tip all the way back to the left atrium. If your catheter tip was in Zone 2, the alveolar pressure would be squeezing the vessel and giving you a falsely high number. It has to be in Zone 3.
And here's one last beautiful little piece of physiology for you to file away. The body is incredibly smart. We do our normal, quiet breathing right around our functional residual capacity, our FRC. And it just so happens that FRC is the exact lung volume where the resistance in all those pulmonary blood vessels is at its absolute lowest. It's perfectly designed to make the right ventricle's job as easy as possible. Pretty cool, right?
And just so you know, all the information and the diagrams we've talked about in this explainer were adapted from excerpts from the textbook Respiratory Physiology, which is a fantastic deep dive if you want to learn even more. Okay, so to wrap this all up, let's do a little thought experiment to see if this all makes sense. We've spent this whole time talking about a model that is completely dependent on gravity. So what happens when you take gravity away? Imagine an astronaut floating in space. How do the West zones change? Or do they disappear completely? Have a think about it. And good luck with your studies.